morning. How you feeling? Feeling good? I do. I'm George Johnson, and I'm today's facilitator. And I want to welcome you all. And I also want to thank the Stanford Burnham Medical Research Institute for the use of these facilities. And if you want to use some other facilities, they're out the back door and down the hall. Now, some people wonder if I have short-term memory loss. They say, you know, you said that last month. We have a little protocol here running through a few slides for newcomers and for people who have long-term memory loss or haven't been here for a while. So bear with me as I zip through these things. We got a great meeting schedule. We have 5 experts, not medical experts, 5 experts as patients. So there, we got 5 people like you, and there's a reason for that, because I want you to know that we know what you're going through because we've been through it. And what we have, 5 speakers, 60 years of prostate cancer, must be 100 different doctors, and dozens and dozens of treatments. So we're prepared to answer your questions, and think of some of your questions now. Here are your hosts. The top 5 are the speakers. We brought in the boatload of speakers, and we've got them all here. And then we also want to thank Bob Keck and Bill Bailey, who are helping out in the library, and Jim, who's been our greeter, but Tom is here doing an admirable job of substituting and opening the door. Thank you, Tom. Good for you. Okay, newcomer package have you first-timers got a packet? If you don't, raise your hand. Okay, looks like you all got it. Please fill out the front cover, the yellow page, bring it in here, and this helps us add to our membership, and you'll get a call from Jean here, who will answer any of your questions about our program and offer any help that you might be interested in. Okay, I think you're all familiar with our purpose. Our purpose, and it's highlighted today, is to help you manage your own case. So you're going to hear a lot about that. But we are no substitute for your doctor. He's the medical expert. We're the experts on patients. We might be able to help you come up with some questions you may want to use with your doctor, but we're not giving medical advice or any substitute for your doctor. But we need your support. We're a 501c3, tax exempt. We have small baskets, so we like large bills in the small baskets. And if we could get those baskets passed, we're not affiliated with any religious or medical institution. And so anything you give is tax exempt. Well, for us to be able to support you, we'd like to run down what we have to offer you. First off, we have a website, and that's updated weekly with great talks by nationally known medical prostate cancer expert, Snuffy Myers. We have a library of DVDs, books, and so forth, and what we have a collection of previous presentations. We'll have, a little after next month, we'll have this presentation. And what is helpful here is you don't have to take notes, just get a DVD and all that information will be there right in front of you. We have a snappy newsletter about new research and a couple of new jokes. We have an outreach program, and that's very important for all of us, because of the ridiculous curtailment of PSA testing, we need to get that message out, and we have brochures out in the hall there, and we have some very good business cards that you can take and put your name on it and pass out amongst your friends. We all need to get a PSA test. We'll be commenting in more detail on that later. We have monthly meetings, and next month it's going to be about the diet. We haven't had something on that subject, so this is a special one about what the diet can and do to help you with your cancer, and also other lifestyle changes, things like exercise and so forth. So be sure to come to that one, because that's a special one. Okay, we're going to do our roster of hand waving, and please raise your hand if you're here for the first time. Welcome, welcome. Glad you're here. How many have been recently diagnosed the last few weeks? Okay, you're also welcome, and keep coming back. How many have had prostate cancer for just up to 1 year? Okay, thank you. How many up to 4 years? All right. 5 to 10 years. There we go. Now 11 to 15. See the profile here? And now higher than 15. There's Bob's hand goes. How many years, Bob?
22.
22. Anybody beat 22? By the way, Bob is on ADT. He's on intermittent. He goes off of it when it's way low and lets it rise slowly, and as it reaches an important point, he goes back on it. And he has, you've extended the potential of that treatment. So he's a good example of how intermittent can work. All right, let's go to now the treatment profile. If you've had these treatments multiple times or different treatments, every time I mention the treatment, raise your hand. How many are on active surveillance for the first time? Or still on it? Okay, raise your hand. That's good. That's a growing trend in this group for rather than rushing to surgery or an invasive treatment, you got time, so do active surveillance. And that the effectiveness is now accumulating in the medical research record. Okay, how many have had prostate surgery of all kinds? All right, that was some years ago. More hands would have gone up. That was more of the standard treatment. How many have radiation of all kinds? Okay. How many are on ADT, or what we call hormone therapy? Right. How many are on chemotherapy? Okay, thank you. How many are doing some new treatments like Provenge, cryo? Okay, there's our, and recurrence. How many have had recurrence? There we go. That's for you newcomers, that's a potential event, recurrence. Mine came back after 12 years. And so it can come back. So that's why you certainly need to get a PSA. How many are undecided about their next treatment? I am. Okay. Thank you. It's good profile, and I hope as you notice somebody that was in a situation you're facing, make sure and touch base with them. Okay, today's agenda. Turn this over to Gene. He'll have a few comments to make.
Okay, hopefully it's working. Yeah, you can hear me, right? We're fortunate that it seems like each one of these today has a battery that's starting to fail. I always want to mention a couple of great books, especially for the newcomers. The Invasion of the Prostate Snatchers, which is a great primer for dealing with our disease. There's copies at the library available for purchase, as is the book called Prostate Cancer Breakthroughs, which is also a very interesting book, easy read. That's the book that we are mentioned in, and our phone number's put in there, and I'm getting phone calls nationwide because of that. Another good book is the China Study, which is all about the benefits of diet. And I always have to reinforce this. I want to ask the newcomers, the ones that have come here that are just recently diagnosed, how did you find out? Could some of you volunteer how you found out you had it?
Through a friend. And
But how did you find out that you had the cancer?
doctor at the VA recommended that I, have a biopsy about a year and a half ago.
Oh, okay.
And I didn't, I went through a couple of years, I think just on age, they were just
Yeah,
encouraging people
okay.
to do that. So-
Yeah, I'm just trying to find out, what the first alert was. That's what I'm really looking for, yeah.
PSA was not that bad, 5'1", 5'2", 4'8",
Yeah, okay.
numbers like that.
Yes.
High PSA and a slightly enlarged prostate.
What alerted you to get a PSA test? That's what I'm asking.
When I turned 50, I started getting regularly.
Really, your doctor recommended it, or you did?
No, my doctor.
Okay. After, what caused you to have your PSA test?
Yeah, actually, I had to insist on it. My doctor said no. He said, we
Okay.
don't do that anymore.
That's what I'm after, okay? Because that is the truth, that the Federal Commission, and George mentioned it too, that the Commission mentioned that you don't need to do a PSA test anymore because it causes overtreatment, too much medical expense, which is true. But the fact that they withdraw the recommendation to do the PSA was wrong. What they needed to do is to educate the urology doctors that just because you've got a rising PSA, you don't have to hurry up and treat. And then we have to learn that you don't have to treat right away. That's what it's all about. So the reason I bring that up, and will consistently bring that up, is the best way for you, because oftentimes cancer stays within the family. Make sure your sons get tested. My son just turned 49, and I cannot get him to test. And he's a lot bigger than me, but I'm going to have to figure out a way to do it, to make him do that. So tell your friends and acquaintances the value of doing the test, because ours is a disease that if you catch it early enough, you're going to live with it for a long, long time, as witnessed here already. There's a really good pamphlet that I received from the Zero organization, and they're out on that other table, and it's all about managing advanced prostate cancer, and it's a really good pamphlet, so pick one up to deal with it. Next item, can't see what this says, but Bill Manning is chairing an effort, and with great assistance from our president, Lyle LaRosh, for a very high attendance, we hope, harbor cruise on September 17th. And we're going after corporate sponsors and so forth, so we hope this will be a very well-attended fundraiser. We'll have more details about it as we go along, but this is going to be, hopefully, a very good source of funds for us. I just thought sometimes some of us that are doing a lot of work aren't that visible, but I wanted to introduce each of the directors that are involved here. Everyone knows George Johnson. First of all, he's tall enough, you have to notice him. He's 16 years survivor. 17 years. He's a professional at what he does, and it shows up here, and he's a wonderful facilitator for our meetings. And his own research brought him to the point of being his own case manager, and he's doing just exactly that. He's obviously seeing a doctor, but he's doing it well enough that he knows what he needs to do to manage what's happening with him. And then Bill Manning, up back in the back, he's a professional videographer, and he's the one, pretty obviously, that prepares the DVDs that end up here in the meeting, and that is a very long and arduous task. If any of you have ever tried to do it, and I have, to create, I tried to do some of my family's home movies and convert them into DVDs, which I ultimately did, but it really was hard, really hard. Weeks and weeks it took to do it. But he's our shining example of active surveillance. So if you would need to know the real details about active surveillance, talk to this guy because it's working for him. And then we have John Tassi. He's our webmaster. He took our website from a very complicated site to get around in and into one that's very easy to move about. And if you don't get in there often, please do, because the information changes often. Through that website, you can pick up the DVDs that we have each meeting. We have quite a few of them that are live that you can watch right on the website. And as George mentioned, and Dr. Snuffy Myers does a weekly blog that's very interesting in dealing with our disease. And then our man, Lyle LaRosh, who is our president, he took over the group in 2000 and started it towards prominence. And when he first got involved in the group, he sat down with the then guys that were running the meeting and took 16 pages of notes to learn about our disease and continued that research to the point where I honestly believe now he is at least as knowledgeable, probably more knowledgeable than most urologists in how to really deal with our disease effectively. He's active in our community and responsible for getting doctors to interface. A good example being many of us are patients of prostate oncology specialists up in Marina Del Rey, Schultz, Lamb, and Turner. And he had them have lunch at different times with Dr. Munt, the chairman of the radiation oncology group in UCSD. Now they communicate regularly. Dr. Almeida, same story. So he's very good at getting people to get together for different purposes to help deal with our disease. And Dr. Munt now is so much enamored with what he has found out that he now regularly attends the PCRI meetings each year. Lyle's also an expert in fundraising. He's, for 42 years, had a golf tournament to raise funds. It was raised millions of dollars for many different purposes. So he's our man. Me, little old me, I'm a third year. I didn't mention that Tassie's 8 years, Lyle's 15 years. I'm 13 years survivor. I'm the operations guy, as you know pretty well. I organize the meetings. I add the newsletter, handle the finances, handle the hotline, and my main purpose is to give George a hard time. So George, start it up. Take it off.
Okay, thank you, Gene. He's my boss. I have to be nice to him. He handles my salary performance review.
That's right. John complained so much that I doubled his salary at the beginning of the year, so now he gets double nothing.
Okay, let's talk about case management. Here's the agenda. We have 9 different topics. Let me go through these quickly. I'll be covering the first 2 right off the bat with why you should be doing this and what's special about prostate cancer. I'm sure you've run into people who say, oh, you have cancer too. Did they cut it out? No. Well, you should have it cut out. You know, that kind of decision. Maybe other cancers you should jump to that conclusion, but not true here. Then we're going into case tracking, things you should know and measure, and that's what Bill will be presenting. He may duck out from the table and do some refocusing on the video, but he's very knowledgeable on tracking things because he's in active surveillance. And that's what surveillance is actively measuring the various metrics for your prostate. And then we've always had a question about John. And so he's an expert on asking questions of doctors and how to pick a doctor because he's had dozens and dozens of doctors and he knows a lot about it because he's had at least 5 different kinds of treatments or more. And so we're looking forward to hearing his opinions. And then we got Lyle, who helped me greatly on the subject of biopsy and how to find out where your cancer is. So he's going to be doing numbers 6 and 7. Treatment selection, And here's a case for Gene. He's had a lot of different treatments with a lot of different doctors, so he knows a lot about that. And then he's going to be talking about having a positive attitude. And you never see this guy frown unless the subject is the government task force or engineers. So being an engineer, you're going to see some of those attributes here. Okay, why you should manage your case. You are the most important person on this medical team. Your doctor has an important role, but you should be the head of the team. Your doctor has thousands of patients. He has maybe 10, 15 minutes for you, and he's rushed. He's busy. One thing he tends not to like are questions. That's where you want to consume him with some questions. Don't let them brush you off on that. You are the expert on you. You know how you feel. When I go see my urologist, he says, "How you doing, George?" And I said, "I don't know. That's why I'm here. I can tell you how I'm feeling." And and share those feelings. I feel hurt. I'm sad. I'm depressed, or whatever, because some of that may be due to the treatment, needs modification. And so I'm going to give you some points to kick this off, and it'll be developed further later. Okay, why you should manage your own case. There are many variables about prostate cancer that are impacted by you, your age, your general health, genetics. African Americans in particular should be getting a PSA 10 years earlier than us. The most important concern for you is your quality of life. Quality of life. That includes side effects, but also includes your attitude and outlook, what's important to you in your life with your family members and so forth. And that's where you're very knowledgeable, and share that with your doctor. These decisions are yours. He cannot tell you what you must do. It's up to you to decide what you want done. And so you need to be better informed, and that's one of the reasons we have this group. Your knowledge will build a positive perspective, and that's an important element in your recovery. It's been tested and proven. A positive attitude is probably the best medicine you can have with your cancer. Okay, how are you going to do this? Well, there are choices to be made. Take your time. Think about your personal goals and the therapy as it relates to your lifestyle. Get a second, maybe even a third opinion on the treatment options. I saw 5 doctors. That's an education for me in itself. I looked at different treatments, and then I looked at different doctors. That's my engineering approach. I went to 5 different divorce attorneys to pick one. That was an important decision for me, financially, not health-wise. But so that's my mode, is to check things out. So I encourage you to do that, because there's all different kinds of doctors, and you're going to hear about some of that from John. Get copies of all your medical reports. Those are yours. You own those. Get copies. Ask for them every time. Ask for a copy, and they have to give it to you, and then keep it on hand, because you're going to need that in case you want to see another doctor. Okay, here are some elements that I have learned in case management. The first 4, the first in the top 2 columns, I learned on my own or seeing a doctor. That was 17 years ago. I had a PSA. Fortunately, I didn't ask for one. My doctor did one. Whoops! It was 9 and rising fast. He thought, well, maybe it's an infection. So he gave me an antibiotic, and 2 months later, it had gone up to 13. It was fast rising, and it was not an infection. And so what I did, an engineer, I went and bought a pile of books. There weren't as many books back then, and I got it on the website, and it didn't have that much on it, but I studied everything, and those are the 4 things I learned. It recurred. I came back here, and all those other things I learned in this room, either from the speakers, from that table over there, or from my good friends Lyle and Gene. Were very helpful, and some of you members. And so these are the things. We're not going to cover all these. We'll cover some of them, but these are the things that I've learned that are important in my engineering approach, if you will, to case management. Okay, let's talk about prostate cancer. What's different about prostate cancer? Well, it's time. It has slow growth. for most of you. For 85% of you, it's slow growing. You've heard the expression, you'll die of prostate cancer. Rarely, you'll die of something else. Most men, after their death, they find out they did have prostate cancer, but it was not harmful. Well, that's true for most, a majority of prostate cancer people. The thing is you want to find out if you're in that 15 high growth rate. We'll be talking about that. Diagnostics. In the old days, they didn't have any real good diagnostics. And the thing about prostate cancer, the symptoms are not evident until maybe it's too late. Blood and pain and things like that don't occur. I had no pain, even after it recurred. No pain, no symptoms whatsoever. It was a PSA. That's why it's important to get a PSA test, because you can't wait for symptoms. Their ruling, and it's misinterpreted, they don't suggest that you have a PSA test unless you have symptoms. Well, they don't want you to have an early test, but what? They want a later test? A too late test? Maybe it's too late. So that's why you need early detection. And another element here is the biopsy approach. You'll hear about this, but in prostate cancer, they tend to do untargeted biopsies. It's the only cancer that they don't aim at the tumor. That's the way they're trained. That's unfortunate. Can you imagine that if you had breast cancer, they would do the untargeted, just jab all over the breast? No. Okay, that's an aspect that adds to the complexity of the program. The region in the body, I heard a surgeon say, that's one of the pelvic area, one of the most difficult areas to do surgery in. You ever try to work under a kitchen sink? I mean, you got the hot water, the cold water, the electrical lines, the dish, garbage disposal, all that stuff going on under there. And you might include also the TV cable in there, to make an analogy, for pleasure and entertainment. Those wires are in there too in the pelvic region. And so what happens, you get somebody going in there and messing it up like I do, and you're going to have all kinds of problems. Years ago, the only treatment was surgery. And it used to be, and that's not that long ago, where the doctor would want to withdraw some blood from you a week or two before the surgery, because they needed that for a transfusion in case you had a lot of bleeding. Patrick Walsh, who's the eminent surgeon up at Johns Hopkins, says, anytime the doctor says we need to get some blood from you for a possible transfusion, don't do it, because if he's doing it right, you don't need extra blood. So, but I just bring that up to show you how archaic it was. And in that region, it's critical. Fortunately, we've had technology developments. The technology was very slow in growing. They were doing primarily surgery or massive radiation, broadcast radiation, as opposed to targeted. And now there's been a lot of improvements. Some of that's come from the technology in breast cancers. Some of the medications and things like that are appropriate for prostate cancer. And this is all now accelerating. That's why you want to be in this group, to be abreast of what's going on. And there's opportunity for drug trials that you may want to participate in. And so that all leads to some wonderful treatment options. There's a long list, more than 16 different treatment options you may have, and a few of those may be just the perfect thing for you. So that's something for you to be aware of. Okay, that concludes my part of the presentation. And any questions on that? We'll open it up to questions for each individual speaker. And if I don't get a question, that means I've done my job. Okay, we'll open this up. We're going to allow questions after each speaker, and then at the end, we'll open it up to any kind of question.
You had color Doppler on that first slide. How effective is a color Doppler diagnostic?
Well, I think the proponents and the one that helped me on that was Lyle. Will tell you why. There is Doppler, and that's used more or less to look at the prostate as an area. And that ultrasound is not used to locate the target, or color Doppler by Hitachi. focuses in on the tumor area that allows you to do targeting. So that's very special. It's not very common down here. Lyle will expand on that point, and his really awareness of a wonderful guy, Duke Bond, who's a real expert on that subject. Any other questions? Yes, Tom?
I hear mostly about urologists, and my urologist is not involved much. I go to a hematology oncologist. So what's the difference?
Well, the one thing about different about prostate cancer that I didn't mention, when you're a general practitioner or a primary health care doctor, does a PSA and it says it's rising or it's high, immediately he will say, go see a urologist. Every other prostate cancer, they normally say, go see an oncologist. Well, to this doctor, he thinks urology, you'll need a biopsy. He doesn't do biopsy, he sends you to a urologist. The urologist is trained as a surgeon. That's the only cancer the first doctor you see is a surgeon. And so that's the tendency for urologists, because not that they're narrow-minded, but they're experts in one field and they will prefer to do that. You'll hear some more about other doctors from John.
My cancer is down to the bone, so I've been taking blood infusions. I've had about 12 infusions since November, and it's helped.
Yes, but that had to be specifically requested, did it not?
Well, it was their decision.
Okay, thank you. All right, any more questions? Okay, Bill? What's different? Let's see, our next subject here is case tracking. Taking his headphones off.
Am I going to sit here?
Yes, second seat.
Okay, good. Well, that's all right. Well, let's sit here. You're going to change the slides.
Okay, I'll do that for you.
Thank you.
This is our first rehearsal.
Our dress rehearsal was canceled, so. So my topic is case tracking and things that you should know and measure. I guess there's the adage of how can you know where you're going if you don't know where you've been? Your doctor is not going to be tracking your case any more than each visit with a line item in your chart, which of course he won't review until the next time you show up, and that will be about 15 seconds before you sit down, and then you will continue. So taking the two most important parts of tracking on prostate cancer, your Gleason score and the PSA. The first thing you need to do is to understand your Gleason score and what it means. That the two grade numbers that add up to your Gleason score are as important as the total. And a lot of times the doctor does a very poor job of explaining what that is, just simply saying, oh, well, your Gleason is okay or horrible. And in fact, it really does matter how those numbers are arrived at. The stage or degree of risk is measured by an analysis of the cancer cell structure and location that's taken during the biopsy. And the more concentrated the cells look, then the higher the number that's assigned. So basically, you're given two scores, and the first is the largest concentration, the second is the next level of concentration, which totals your Gleason score. So from that point, you're basically given a course of action based on those numbers. So with each subsequent biopsy, a pathologist will, of course, regrade this, and it's important to keep track of this yourself personally, whether it's on a spreadsheet, whether it's in a binder. This is information that is important over time. So the total Gleason score could be from 6 to 10, 6 being the least aggressive, 10 being the most aggressive. In my case, mine was 6, least aggressive, and that facilitates my being on active surveillance. So I have only had 2 biopsies, and both of those came out with Gleason 6. However, my PSAs I've been tracking for the last 6 years. So having this information available is very, very important. As you've heard, the PSA test being basically dumped is a travesty, and it's important that everybody continue getting PSAs, and most important, tracking it. The thing is that you don't want to get in a situation where a PSA is a snapshot, where you take any one reading and use that as a criteria for a treatment, because the PSA is often, like I like to refer to it as like a bouncing ball. So it's really the tracking over time that is the important part of the PSA, not any one reading, because you have spikes sometimes. These can be caused from many different reasons: an infection, irritation, bike riding, sex. There's lots of reasons that can cause a spike. So it's important that you track it over time so that you see that if there's a steady rise and no dips, then there's probably reason to be a little more concerned and do more investigation. So a steady rise in multiple PSAs over time can indicate a need for more testing and a possible treatment plan. The doubling time is the measurement of aggressiveness of the cancer, the months or years it takes for the PSA to double. You should track or plot the PSA numbers over time to make this measurement. So again, it's very important that the time element be in here, and your doctor may or may not even be taking that into consideration, because if you go in and you have a test and you had a spike, then of course there's a large chance that they may say, oh, well, of course you just had a spike, you need a biopsy. And that's not true. So what you need in a situation like that is a second PSA test later on, and see where that goes, and another one after that, and track these yourself, because again, he may or may not put a correlation between them, rather than just simply saying, well, you've got this high number, so you need a biopsy. So the frequency of your PSA should then be less than your doubling time to best manage your case. Then on the Johns Hopkins website, there's a tool called the Parton tables, where there's 3 drop-down boxes that you can put in your personal information, and it basically divides up into 4 categories of potential aggressiveness. So this is something that you can do. It's very simple. It's very simple to execute, and the 4 different areas is the probability of the disease being organ confined, meaning within the prostate. The second is on the extension. The third, has it penetrated the seminal vesicles, and then of course 4th is the worst, where it's out floating around and into your lymph nodes. So basically, by putting these 3 different scores in here, you can get a feel for just how aggressive your disease might be. So this is another thing that you can track over time and keep in a spreadsheet or in a binder, and have an idea that what you're doing makes sense, and then be able to discuss that with your doctor.
Okay, time for questions.
Any questions?
Oh, I pointed to him first, sorry. Go ahead.
Okay, well, we're going to scan you all. We'll start over here.
What do you use, what technique do you use just for tracking doubling the time? Just simple?
I use a Excel spreadsheet to track my scores.
I mean, you try to use it in a logarithmic basis or just simple?
Well, I actually, just for grins, make a chart out of it too. But, putting all the numbers in is an Excel spreadsheet.
And just look
And
at
then watch the bar chart.
Okay, here.
Actually, it's also about doubling time. I haven't heard anything, I've heard all this talk about doubling time, and also that it shouldn't rise by so many points within a certain period of time, but what is the doubling time one should be looking at? Is it months, is it years? And how does that compare to doctors who say it shouldn't rise by so many points per year or such?
Let me comment on it, because this is one of my big important things, is doubling time. And it's, as you know, cancer is uncontrolled cell growth. The cancer cells don't die. They grow, where other cells will mature and pass on. So therefore you're tracking how fast those cell structures are growing. And the best indicator is your PSA. And so what you plot, and this is where when I went to my doctor the first time, my PSA was 9. And then after 2 months of antibiotic, it went up to 14. So boy, that's a sharp rise. It's the slope of the curve, not the units by themselves. So that's why it's important to track. And that means my doubling time is 3.5 or 2.5 to 3 months. And doubling time means it doesn't go 2, 4, 6, 8. It goes 2, 8, 16, 32, and so forth. So mine doubles in 3 months. So that's why I have to have it to make sure it's effective. And then when I went on certain treatments, it would go boom, right down. And then it would start to rise again. So it's the slope of the curve, and that's best expressed by doubling time. It's the time if you have a PSA of 6, and it goes to 12 over what period of time? And generally, for most of you, it's like 3 or 4 years or more that it doubles. It's in the 15% where it's fast rising. Less than a year is a critical amount. See, but you can plot that out. It's a good question to ask your doctor, because it reminds him, oh yes, what was your PSA? See, I've run into, oh, your PSA is low. Wait a minute, but what was it before? Was it lower or higher? So that's why it's a good idea to ask the doctor, what's my doubling time? And he's going, ooh, you tend to know what's going on here. I better check.
Well, another part of that too is whether you've had treatment or no treatment. Because if you've had treatment and your PSA is down to close to 0, then the doubling time perspective changes dramatically. Because then you can have, say, a 0.4 that suddenly goes to 0.8. Well, that's a dramatic doubling, or just a huge percentage rise. Whereas for someone who's not had treatment and maybe theirs goes from 7 to 8, well, that's not that big a deal. So it does matter whether you've had treatment or not relative to PSA curves.
Great question here.
I'm just going to make a comment that there are websites for putting in your numbers, and that there's a calculator. If you just do a search for PSA doubling time calculator, you'll find that's the part of tables, but
No, I think he's talking about something different.
yeah, it'll give you your doubling time.
yeah,
If
right,
you
on
just
doubling time, yes.
insert some numbers, your numbers
Right.
into it,
Yeah.
should be able to find it.
Yeah, just search doubling time, prostate cancer doubling time. Question over here?
For me, sorry.
You're-
Once it's metastatic, what does the doubling time mean then? Because, I mean, his doubling time was like 100 to 200 in like 2 weeks, so the PSA. So what does it mean once it's metastatic? Does the doubling time Because this tells like it's stage 1, 2, 3, or 4, but once it's already stage 4, then, I mean, the calculators don't help you, because I searched all over the internet, and I was like, couldn't tell what what his doubling time meant, because it just gives you the stage, and we already knew the stage.
Well, what you're talking now is a very advanced, serious risk stage of cancer, where these metrics are not that applicable. We're talking about before it goes into metastasizes. Okay? Yes, question?
How do you know when they let the doctor do the first biopsy?
We'll be covering that under the biopsy. Okay? Yes.
Talking about doubling time, I had a test in 2011 at 3, and the next one in 2014 at 6.2, say. The doubling time calculation might be meaningless because I don't know what happens between 2011 and 2014. It could have jumped in 2013 from 3 to 6. So in that case, I think my doubling time is meaningless.
Well, I think that's where the issue of frequency of doing these on a regular basis, annually, if not twice a year, so you've got a much clearer idea rather than a big, huge gap. The fact that it went from this point to this point in 4 years can be perfectly normal. So, again, I wouldn't want to use the doubling time concept on something like that.
Okay, I have, just want to clarify before we move on. What happens when you get a PSA and your urologist treats you and so forth, you get your biopsy and all, then you go back frequently to your primary care physician. That's what I did when my PSA went down. And I went there, and every time I saw him, I said, "Oh, will you, for a blood test, include a PSA?" "Oh, yes, that's right." And then when I go visit him, he'd run down my cholesterol, and I'd say, "What about my PSA?" Oh, yes, it's low." Well, he kept saying, "It's low." Well, it turns out I didn't know till I got here, and he didn't know that after you have treatment, the whole scale factor, remember 4 was a magic number, that whole scale factor drops down into the decimals. It was low but rising. It was 0.2, 0.3, 4, 0.7, and I stopped getting it, and then it was 14. And so he didn't know that the whole scale factor of the PSA changes after treatment. It's supposed to go to 0 when you have surgery. It won't go to 0 on radiation. But you need to know that and make sure your doctor knows that. And that was the problem with the primary care doctor, not my urologist. So I went back to him. Okay, let's go to John, and John's going to talk to us about some questions. And
So you can open the door.
okay, John.
Good morning.
Good morning, John.
It's a great day to be alive. It really is. So first I wanted to let you know why I can stand up here and talk about prostate cancer. We're in a very exclusive club. Only 1 out of 6 men are allowed in this club. It's a very positive way of looking at it. I try to look at the bright side of things. In 2005, I was diagnosed with BPH, benign prostate hyperplasia. And my PSA was 4. And they said, "Oh, you've got an infection." Does that sound familiar? So then, in 2007, I got my invitation to this fine club. In November, my PSA was 19. And very similar story to George's. My doctor says, "Oh, you're fine, you're fine. You're too young to have cancer." So that started quite a bit going on. They did a biopsy. Turned out I had a Gleason 4 + 5. That's a 9. You learned about what that means. That's not really bad, but it was 1 point away from being the worst you could have. It was a T2C, had no positive margins. And that's a key, because they told me by their biopsy that the cancer had not spread outside the capsule. So that was great. Had my surgery. 2 months later, had my PSA done. It was 0, less than 0.002. So doctor said you're cured. So I went ahead and in 6 months after that went to go have my PSA done again, just because I'm an engineer. And lo and behold, my PSA was then 0.2. Well, I had no prostate. How can I have a PSA? So that then December went back again, couple months later. My doubling time was 2.5 months. So apparently that non-positive margin was not true. So since that point, I had surgery. I then immediately went in for IMRT, which is intensity modulated radiation therapy. I had 37 courses of that, which turned out to be 67 grays. That's how much you get. I then went in for Taxotere, chemotherapy. I had 5 courses of that. Now, the FDA recommends 75 milligrams every 3 weeks. They were giving me 200. So I had quite a fun time on that. Immediately after that, I started on androgen deprivation therapy, ADT, and I was on that for 15 months. My last treatment was in 2009, May. So now I have gone, 6 years? PSA is still 0. So we threw everything at it. I was young. And that's why I think I can talk about what we're going to cover today. It's very important when you have as many treatments done as I have, or even just one treatment. You need to have what's called a master history list. And that's what this 5 pages is. In it is your prescriptions, doctor, the date it was prescribed, any over-the-counter drugs you're taking, again, date you started those, strength, any allergies, what medicines are you allergic to, a highlight of any surgeries, just one little paragraph of any surgeries or procedures you've had done that's encapsulated, anything that's been discontinued, medications you were on, but you're now off, dates and who that doctor was, why you were discontinued. Then I have a list of all my doctors and their numbers, their addresses, fax, websites on one page. Then I track, this is my tracking of everything dealing with prostate cancer that I have done, the date and the procedure and what the result was in a very bulletized, itemized list. And then the last item is any generic or any, can't think of the word. Not generic, but over-the-counter drugs, anything that is like mushroom extracts, supplements, that's the word. Any supplements, list the ingredients so that if a doctor wants to prescribe a medication to you, you can look at that and he can say, oh, we can't give you that because you're on this other thing. So this always goes with me to any doctor appointment. I hand that to the nurse and they look at it and they go, wow, we've never seen anything like this before. The other thing you need to do is keep all your test records. That's what this folder is. Every test I've ever had is in here. The doctor asks, what was this test? As he looks on the sheet, I can go right to it every time. This goes with me every time to the doctor. That's got all my radiation, all my chemo records, all my doctor visits, all my tests. Now that you've got an idea of what you're doing because you're documenting it, you're now becoming more of a case manager. You're managing your own case. Does your doctor do this for you? Does your doctor do this for you? No. You need to do it. You need to research on your own in preparing for your doctor visit. So ask friends and family. That's the first thing to start. You trusted people in the family, anyone maybe that has had prostate cancer, ask them who they would recommend. Use the internet, some very good sites, American Cancer Society, PCRI, and of course our site. Prepare a list of questions you want to ask the doctor. And important, make 2 copies. One to hand the doctor when you walk in the room, and your copy. And you ask him the questions. And a really important one is always request the last appointment of the day on a Tuesday, Wednesday, or Thursday. It's been proven you never want to buy a car that was made on a Monday because everyone's just getting over the weekend and whatever they were doing. You don't want to buy one on Friday because that was built on the day everyone's waiting for the weekend. Same thing with people. So Tuesday, Wednesday, Thursday, last appointment of the day. And we'll cover why that is important in the next slide. Oh, I thought you were going to push the button. Okay. As I said, and George mentioned, I have a few doctors. Actually, I have 13 on my team currently. And I have interviewed many more than 13. I've got a primary care doctor who was the first one that suggested maybe you should go get a PSA test. I have cardiovascular, sleep medicine, internal medicine, homeopathic, very important for some side effects to go with natural. Orthopedic, nothing to do with prostate cancer. Had to do not taking care of my body when I was younger. And then we have the ologists. You have the gastroenterologist, urologist, oncologist, radiologist, audiologist, rheumatologist, and ophthalmologist. All of those are on my team. They have all been researched. Someone has said they are good, or I have researched and found out that they are good. So you're going to have your initial visit. What do you ask your doctor? There's a really good list of questions up on the internet from the American Cancer Society. It's about 15 pages. Just about everything you could think of you would want to ask a doctor is in there. And I would highly recommend that if you need that, to go up there and read through them all. So what you want to find out from your initial visit, this is your initial visit to your prostate doctor. Ask him or her, if you had prostate cancer, obviously only him, who would you go to and why? That's always a good question to ask. One doctor was so appalled at that, he was not my doctor after that question. Incidentally, I've fired 2 doctors because I was very uncomfortable with them. And you need to treat your doctors like you would a car salesman or a commodity. You are paying for their services. If you're not feeling comfortable with them, if there's not a good rapport, you're probably best to look somewhere else. Then you ask them how many patients they've treated, how many successes, how many reoccurrences have occurred, and then ask why have they reoccurred? What was their opinion on why? And then ask the doctor, what's your recommendation for me? And what alternate plans or options are out there? What possible side effects are there from each option, from your plan? And if I have side effects, how long can I expect them to occur? When do I expect them to recur? With chemotherapy, you have quite a few fun things that happen while you're on it. Radiation, it's down the road many years. And can these side effects be treated? That's a very important one. That's one where the homeopathic doctor comes in. A good homeopathic doctor will know what will treat certain side effects. Do not let the doctor rush you during your visit. That's why I suggested the last visit of the day. Keep asking your questions until you're satisfied. Maybe ask it a different way or put it at the end of your list and ask it again after you're all done. Let the doctor think about it a little bit. And don't be afraid to thank the doctor, get up and walk out. If you're not getting your questions answered, you need to find a doctor that will do that for you. On follow-up visits, that's provided that the doctor wants you and you want that doctor. On follow-up visits, you ask them overall, how am I doing? That was mentioned both by George and by Bill. Ask the doctor, how am I doing? You know how you're feeling. Ask the doctor how you're doing. Ask them what's your level of cancer, what the aggressiveness is. What's the Gleason? What's the T score? T2C, T3C, etc. And then specifically, walk through the test results with him. What do they really mean? Ask, when should you get your next PSA test? I get mine done every 3 months. It's very important that you work with your doctor to determine what that time is. And that gets into the doubling time. Or if you have no prostate, you should have 0 doubling time. Doctor selection process. I have selected quite a few. Good place to start is to ask the doctors that you trust. Who would you go to for this condition or that? Doctors generally will recommend someone first in their own group, or if you've got a very good rapport with them, they will recommend someone that they truly believe is the best. And then once you do find that, ask your friends, family, what do they say about that doctor? Do a Google search. It's amazing what you can find on Google about doctors, good and bad. And then finally, what does your gut tell you? How is that rapport when you're sitting there across from your doctor? Do you feel comfortable? Can you talk to them as though you're talking to a friend over coffee? If that's the case, they answer your questions. That sounds like a pretty good rapport. Second opinions. Now, they recommend, they being the different cancer societies, recommend that if your Gleason's over 6, you want to get a second opinion. Always get a second opinion on anything dealing with prostate cancer, period. That is my opinion. Had I done that, I probably would have been much better off and not have to go through everything I went through. But I listened to the doctor. He said, oh, it's low. No, it wasn't. It was high. Definitely get a second opinion before any invasive treatments. And if it's going to affect your quality of life, that's a very important issue. So now you've had your appointment, you selected your doctors. Now you go home with this mound of information. Do not rush your decision. That is very important. And the treatment, the decision is yours to make. Not the doctor's, not your friend, not your brother, it's yours. Because you are the one that knows what you can live with, possible side effects, and your quality of life. Because each treatment has its own pluses and minuses. Take your time, process all of the information, search. Consult with others who have gone through prostate cancer. This is an excellent group for that. And more importantly, do you feel that the doctor that you're seeing shares your goals? And that's it.
Okay, questions? We're here.
You said you had 2 surgeries. The first surgery obviously was to remove your prostate. What was the second surgery for?
I had 1 surgery for prostate cancer. I've had 12 total.
Oh, I thought you said you had 2 surgeries.
Oh, sorry. No. No, I've only had one prostate removal. But I've had radiation, chemo, ADT after that.
Okay.
Question over there.
Question about the second opinion process. When you get a second opinion, how do you use it and how do you make a decision if you have a disagreement?
That's the maritime rule. You always get 3. I would get, on my prostate cancer the first time, I had one opinion, which was you need surgery, you need it immediately. I had surgery. The second time around, I went and consulted a doctor about what should be my next course of action or courses of action. That's when we sat down, drew out a table and said, if you do radiation, if you do chemo, if you do ADT, if you do some other things, lifestyle changes, you've got a 80% chance of living past 5 years. So that was the second opinion. And then I would go to the different doctors, the radiologist, the oncologist, homeopathic, to find out what they had to say. I put it all in a big mound of information and I sifted through it. And this group, that's about when I started coming to this group also with Gene and Lyle, very helpful. They were very helpful in showing me the path of how I needed to have treatment.
Let me just add a real story that was in this room. When I first came in here, I met a gentleman who worked for the same firm I consulted with, and he had just visited a urologist. And the urologist said, you're lucky, you have prostate cancer, you're lucky I can do the surgery next week. And he said, well, let me get a second opinion. And the surgeon said, you don't have time for a second opinion. So what he decided to do was to go up to Ventura, and he went the day before I did to Duke Bond and had a ultrasound. And what Duke does, he does an ultrasound, looks at any signs of tumors, and at one point at the end he will say, I think you need a biopsy. He doesn't do one automatically. And in this case, he told him, you don't need a biopsy, but you need to come back in 6 months or a year. You do have cancer, but it's not critical at this point. So I went there and he said, you need a biopsy and so forth. But this is what is so impactful, who you get on that second opinion. And the thing is, if you're going to get a second opinion, we recommend you go outside that group to an independent person, because if it's in the group, guess what the doctor, the second doctor says, oh, it's my golfing buddy, Charlie, and I don't want to be on record on the computer of disagreeing with him, and he's a wonderful friend. And so you don't get a real second opinion, you get a second verification. Okay. Question here.
Yeah, I just wanted to circle back to it. You had a slide, and I thought you were saying, referencing getting a kind of a second review of your biopsy to see if the second person agrees with the Gleason score. I mean, you wouldn't have to have a second biopsy. You would just somehow get the slides or whatever the biopsy material is.
I believe, and George, you can answer that. You can answer that. You can send your slides.
Lyle will cover that under biopsy. Okay. There's a good answer to that. And the answer is you don't need to have another one. You send the slide. Question in the back there.
Okay, I'm currently under treatment. Started out with a urologist, went to a radiation guy, picked radiation over surgery, had a choice. Okay, and so I picked radiation, went through the process. And now the guy I'm seeing right now is a radiation oncologist who's handling my case, and he has a group of doctors that pound my bones and so forth afterwards. My numbers look real good. And my question is, when do you go back to your urologist? Okay, and because obviously this guy's a radiation guy. He's an expert in that area. And if my numbers turn, I know that the course of treatment most likely will be radiating the cavity. So I'm thinking that this is the right guy to handle my case right now. He's monitoring every 4 months. I'm getting a PSA and it's going down, down, down. And so everything is looking good, but I'm also saying I started out with this other urologist essentially who would have performed surgery had I chose to go that way. And he supposedly knows more about urology, all right, as opposed to radiation, and what side effects might come up here as time goes by. Okay? Because when I went through the radiation, I did get some minor side effects, okay, were minor. So I have that issue of I'm talking to this doctor, I'm talking to their nurses, and so forth, and in the background there's this vibration. Shouldn't that be going back to a urologist essentially, after the treatment's over, if it's ever over?
I can certainly speak on what I've done is I see my urologist once a year. So, and that's just more or less a checkup. I see my radiation oncologist once every 2 years. I see my chemo doctor every year. And again, nothing's wrong. We're checking in. He's asking, how is everything going? I bring him the book. We look through it. We talk about maybe new articles, because the Taxotere, which was what I'm on, or I was on, the 5 courses, I'm going to have lifelong problems from that. But that's the bad news. The good news is I'm going to have a lifelong of problems from that.
So, but basically you don't see a conflict in that area where essentially the radiation guy is obviously very familiar with prostate cancer because that's his main source of business essentially, but he's not really a urologist in the true sense of the word.
Lyle, would you?
I'm just going to say to you, I mean, after you listen to John's list of his so many doctors, he's got a lot of doctors. Well, after you have made a decision to use radiation therapy for your prostate cancer, then you no longer need your urologist for prostate cancer, period. There's no reason to go back to him anymore.
Okay.
Unless you have some specific urologic problem.
Okay, great. I wanted to hear that answer because that was my feeling, because this guy is setting up a long-term plan for me. Okay, and right now I'm on 4-month cycles, because I think he's looking for what's called nadir. Nadir means when you get the lowest possible PSA point for monitoring for doubling. And, you know, and he's saying the same thing. We got it, no problem, it's looking really good. But I know the reoccurrence numbers are 40%, so, okay? So that's wonderful, but, you know.
Don't take your Chevy to a Ford dealer.
Exactly. Okay.
All right, one more question. Okay.
Yeah, John, I'm curious about the insurance. Have you had problems with them paying for all these different visits and doctors and appointments? You run into problems?
I have not. The company I work for happens to have a very good plan. So total out of pocket, we added it up. It was somewhere around $500,000 for all my treatments if you looked at the EOB's, explanation of benefits. Out of my pocket was about $2,500.
You're not on Medicare, obviously.
No, I'm not quite old enough for that yet. All right, thank you, everyone.
All right, we'll have time for questions after we have 2 more speakers, and then we'll open it up. Okay, Lyle, let's hear about biopsies.
When I was first told by my general practitioner, my friend, he said, your PSA has gone up, and so I'm going to send you in for a biopsy. So I went in, I had it done, and I called him the next day, and I said, why didn't you tell me what they were going to do to me? And he said, if I told you, you wouldn't do it. So this biopsy thing is become the real issue about PSA testing, and what do you do with it? Just because your PSA goes up a little bit every year, that's normal. If your PSA, you ask the question, what's your doubling time? Your doubling time could be 1 month, could be 6 months, it could be a year, But the normal progression of your PSA is based on your age usually and the size of your prostate. So most doctors don't include those two factors when they say your PSA is going up. So biopsies, they say today still, most doctors say that they're still the primary tool that we use to determine your Gleason score. And so we've discussed the Gleason score, but your Gleason score under a normal biopsy, which is a random biopsy, could be wrong. The problem is that your cancer tumors have a center, the nucleus, and the Gleason score is usually the highest at the tumor, the center of the tumor, nucleus. But if they do a random biopsy and they're just sticking needles in you, 12 of them usually, but they do saturation biopsies, I'm going to tell you, they make you sick. They do 36 samples. So if they just randomly take these samples, if they hit the tumor, it's by luck or accident. Now, if you're just a reasonable person and you were going to shoot at a target with a rifle, you'd aim at the bullseye. A targeted biopsy is that. And the way that that's done is by a skilled person using either ultrasound technology, as Duke Bond does, or using an MRI, which is now being used more often, or a combination of those two. Now, color Doppler ultrasound will only give you a two-dimensional picture. You introduce the MRI into that, and you have three dimensions. So when they stick the needle into you to try to find how far in it should go, using a standard color Doppler ultrasound, they're just doing that by guess and by golly. But using an MRI-assisted biopsy, you can get a three-dimensional specimen. Okay. And as it says here, prostate cancer is probably the only incidence of cancer that they do it in this fashion. I mean, they used to do that to women. They'd just be sticking holes in them. I mean, but you know, then they taught women to feel for lumps in their breast. Well, that's the tumor, so that's where you take the biopsy. So everybody gets that? So for you guys that haven't had a biopsy and you're watching your PSA, remember that. That's critical. Don't just go get a standard biopsy. Okay, so that's what all that says. And by the way, the doctor that pioneered the use of targeted biopsy is Duke Bond. And he did that using color Doppler ultrasound so that you people that are newly diagnosed and you have not had any advanced imaging tests, then you should contact us for that information. Because if you're if you don't know where it is, I'm going to tell you in the next slide, if you don't know where it is, you don't really know how to treat it. I went up to Duke Bond's office once and took a buddy of mine up there, and he looked at him and he said, whatever you do, tell this man, do not have surgery. The reason was that his tumor was at the closest point to his rectum, and it had already escaped the gland and was gone into the fatty tissue, and the next stop was his anal sphincter. So if you can imagine how bad that will be, the man went and had surgery. It blew me away. And to this day, he's still fighting that same problem. At lots of different things. Yeah, I did, that's right. Okay, so I was going to use a pointer in this case. Does this thing work?
Yep.
So this is a graph of what they're looking for when they do the biopsy. And it shows you these are the normal prostate cells. And the scale, it goes down to 5. And as you can see, the degradation of the membrane of the cell structure deteriorates as you get further down. So all the way from here, where you have nice clean definition of circle, all the way down here to you can't tell what the hell it is. So when they look at your biopsy, your samples, they're looking for the largest number of cells in the first case. So that if you had a 3, so they're going to look, and that's most of them, and then the rest of them are, let's just say a 2, that would be a 5. But we really are looking for is a 3 plus 3 as the threshold on a biopsy. And a 3 plus 3 is considered low risk. So now that if you had a 3 plus 4, that means that you're at a higher risk.
Let me show you the next one here. This is the actual photograph.
So let's go back to the other one. I'm not through with that other one. Okay, so that if you take a sample and all he sees is this, and it's a 5 plus 5, that means you have serious prostate cancer. Now, we go around talking about active surveillance all the time, how 85% of men don't have to worry. But I'm telling you, if you have a Gleason of 10, you better do something about it. So you can't be fooled. And that's the problem with not having a PSA test. Because if you don't know your PSA score, you don't know your doubling score is, it wouldn't go in and maybe try to find out what your Gleason score is. Okay, any questions on that? I don't want to. Everybody understand? Okay.
So I have one question. Now with regard, to the evidence that they have there, if you have cancer, like in my latest biopsy, there was an increased number, and it was the random, I'm sure. It was whatever the standard VA hospital method is. And it's the 12 shots, as you were describing. It had gone from 3 samples in my first go around to 7 in this one. Okay, but in both cases, my PSA, there was no rise, still 5.2, 5.8. Now, the doctor told me at that time, he said, well, we're not going to do a bone density, we're not going to do an MRI in that because there's no, with that low PSA, it will have been contained to the prostate. Does that make sense?
Yes. Okay. The thing is that because they did 2 random biopsies on you, that they did not duplicate the biopsy. Right. They did 2 random biopsies. Yes. So it's just the difference in how they did it that they found more evidence.
That's right.
But had you gone to a targeted biopsy and they took it the same place each time, then you would have a true picture of what's going on in there.
Do you suppose that they don't do targeting? Targeting just makes sense, okay, that they don't do it because of cost reasons?
It's the inexperience and it's the education. Now, there are many places in San Diego that we have convinced them that this is what they're supposed to do. And that at UCSD, for example, they're doing MRI-assisted biopsies. That's just happened in the last year or 2, and I would like to think that we had a lot to do with that. Because we press people to move forward. And UCSD is we're very close to them as medical. If we had a medical team, they'd be on it. Yes?
Do they give Gleason scores to tumors that have left the prostate?
I can't hear you.
Do they give Gleason scores to tumors that have already left the prostate? Like if you get a,
Well,
if you get a biopsy on a tumor in your spine.
Well, the way that you find if the tumor has metastasized, I know you asked that question before, so that's what you're referring to. How do you know if it's metastasized? Okay, we go to the next slide here. Okay, so this is once again about the reading the sample. They do this with a microscope, by the way. This is not high tech. They put your slides underneath a microscope and compare the tissue. And when we say to get a second opinion, I had my first biopsy done in San Diego, but then when I found out that I needed to get a second opinion, I sent it back to Johns Hopkins. So what happens when they take your samples, they store them in a wax substance so that it's available for further testing. So to get a second opinion on your biopsy sample, all you have to do is call your doctor and you tell them where you want them to send it. So if you wanted to get a second opinion on your biopsy, you send it to Johns Hopkins, to Dr. Epstein, who is the best in the world. Okay? But I have to tell you that a lot of the time you're going to get a higher score from him because he's going to err on the side of caution. But that's just the way it goes. And I didn't say, and we don't have it on here. We'll get to it. But you can now do an MRI targeted biopsy without getting a biopsy. And the results from the MRI at UCSF, Dr. John Kurhanowitz, is such that they can give you a Gleason score without doing a biopsy. Now that's revolutionary. And it's being done, but they just, first thing is you have to have somebody who knows how to do it.
And pay for it. Yeah.
What?
And somebody to pay for it.
Yeah, somebody to pay for it. Okay, do your doctors know where the cancer is? Well, when you think about your prostate's as big as a walnut. So when they're doing these random samples and they're just sticking holes in you, they basically put it into quadrants and try to take 3 samples out of each quadrant for the total of 12. And so that a Gleason of 6 is a candidate for active surveillance. So the general standard is if you have a Gleason or a PSA of less than 10 and a Gleason of 6, and you have had some other testing, such as color Doppler ultrasound, so that you need to know where it is. If it's in the periphery, which is close to the membrane, it could get out very easily from there. If your tumor is up by the tubes for your seminal vesicles, it's going to go up into the tube to your seminal vesicles. So you're not going to get this from a random biopsy. Now, if you go to, I still believe Duke Bond is the best in the world. He's in Ventura. But we have other people that are learning how to do this, that you can be a candidate for active surveillance. And so even the glossary of calling something prostate cancer is changing. If you have a Gleason of 6 and a score PSA of less than 6, they're not going to call it prostate cancer anymore, because all they're going to do is scare the hell out of you. That's the problem with the PSA test. They scare the hell out of you, then you feel compelled to go get some treatment. Okay, so these are thoughts about the slow growing. Now, if you have a Gleason greater than 6, and the problem is, how many guys in here have reoccurring after surgery? Okay, quite a number. So you have to say to yourself, the first thing you say, geez, I don't have a prostate. How can I still have prostate cancer? Well, the answer is they didn't get it all. And in that case, it's metastasized. So you have to really start getting on it. And that's when your PSA means the most. The PSA test was not invented to diagnose for prostate cancer. The PSA test was invented for the purpose of monitoring reoccurring prostate cancer. So that if after you've had surgery or radiation, any kind of therapy, and your PSA starts going up, that is why they invented the PSA test. It's to monitor your body for reoccurring prostate cancer. So it has its applications, as we're discussing, but don't be confused. Okay, and some of these other things after you have a biopsy where the doctor tells you you have prostate cancer is bone scan, CT scan, and MRI. So the bone scan, it will tell you usually go get a bone scan. The problem with the bone scan is it will only show you, it'll only appear if the bone cancer is about 50% through the process. So there is another test called the the other one, the sodium chloride. The sodium chloride test, F18, which is an injected substance that will go and attach itself to the reoccurring cancer cells. So we'll get to that right now. Okay, well these are the tests that we discussed. PSA, bone scan, CT scan is to check your lymph glands to see if you have the cancer in your lymph glands, and MRI scan. And the MRI scan is not really a big deal in here, but it is becoming a big deal in reality. You have to go to a facility that has the equipment and they have the ability to read the results. So that's always been a big problem. And I don't know, 5-7 years ago, they started doing MRIs, MRSIs, like spectroscopy, at scripts, but they couldn't read it. So you must be aware of what these tests are and what they're going to mean to you. Okay, so this is the T3 capsule penetration spreading. Now, when a doctor goes in, he does a DRE on you as well as the taking your PSA test. He can feel a bump in there. He can feel a nodule, and he can feel where that is. So when they stopped doing PSAs, they also told you you don't have to do DREs anymore. I don't know if you've noticed that, but that's when they said PSA, they also got DRE in there. Okay, so the question is, if you have metastatic cancer. Now, these tests are important to all you guys that raised your hands that have had surgery or even radiation and you have reoccurring prostate cancer. Now, Ron Abbott down here found the answer for us, God bless him, because it was always the question. If I don't have a prostate, where do I have prostate cancer? So Ron went and found Dr. Fabio, who's now a close associate of ours, and he started using what is called a carbon C11 acetate, and it could be choline, PET CT scan. And so what this is a nuclear agent that they inject into your blood. It only has a half an hour, 20 minutes to a half an hour half-life. So that means you have to have the test done someplace where they inject this isotope into your system, and then they immediately do a CT PET scan on you. So all you guys that are having recurring cancer for almost anything, you can't figure out where it is, you should investigate this test. Now, it's only being done, the closest place is in Phoenix, Arizona, by Dr. Fabio Almeida, who is considered one of the world's experts now. And we have his DVD here. He has spoken to our group. But if the doctors tell you that they're confounded, you should try to get this test done. Now, because it's in clinical trials, it's not covered by insurance. So it's a $3,000 test. But if you're dying and you don't know why, and you have $3,000, I think you should spend it. Okay, so that's what he does. So that is one of the most critical things you're going to get today. Go ahead, Ron.
I have a comment about Dr. Almeida. The carbon 11 acetate PET scan is not, the carbon 11 acetate PET scan is not prostate cancer specific, actually. There are false positives and false negatives too, but you can see in the picture there, a lot of things light up, not just the cancer. And Dr. Almeida is working on a new agent. He may be starting a new clinical trial soon that will be more specific to prostate cancer. The cardinal acetate is an excellent test for us, much better than anything we've had before. Also, Dr. Kwan at the Mayo Clinic does a cardinal 11 choline PET scan, which is covered by Medicare, apparently. The Mayo Clinic can get Medicare coverage for it, so that's another possibility for people.
Quick question. In simple terms, can you tell us the difference between an MRI, a CT, and a PET scan?
Those are all different technologies using different forms of imaging. MRI is magnetic resonance imaging, okay? And so that's it. They're taking slices in 3 dimensions of your body. A CT PET scan is doing the same thing, but it's looking, not the same thing, but they're looking for tumors in your lymph glands. And they inject you with an isotope. So when you go in for a CT PET scan, they inject you. And then you wait there for half an hour, and then you go in and get the CT PET scan.
Drink something too.
Well, whatever they're doing, whatever. And the MRI, the problem when they first started doing MRIs on prostate cancer is that the prostate cancer tumors, look almost the same as the normal tissue on the scan. So they couldn't differentiate one from the other. So that's what they've done in the last one I started 15 years ago. That's what they've done with the MRI. So they've continued to develop it. And they found they had to use a transrectal probe so that they could get a better picture of the tissue so they could tell the difference. But now they've perfected that MRI test to the point where they're saying they can actually tell the Gleason score of the cancer tumor without doing a biopsy.
So the MRI is more advanced than the CT and PET scan?
Yes. I mean, we had Richard Lamb here recently. Richard is a good friend of mine. And he said just unequivocally that the CT PET scan without just anything else is basically useless. He said that it really is something that shouldn't have to be done anymore. And that it's just something, it's like they automatically give you a bone scan. Then they find out that that really isn't very effective either. Yes?
I just wanted to make a comment also. After hearing about Ron's experience with Dr. Almeida, I went to Dr. Almeida as well. And I was trying to get confirmation from an MRI that showed extracapsular extension. The carbon-11 CT PET scan did show that confirmation. It also, as he said, can also spot other things. It spotted a growth in my kidney, which when I first saw the scan on the screen, that's the first thing I saw. I didn't really see anything else. I saw a cherry-sized growth on my kidney. And he said you should have that looked at. Ultimately, I had that removed. It turned out not to be cancerous, but everybody, all the doctors thought it was. So, and I know there's at least one other person that spoke here last year that had a very similar experience, where it also spotted a cancer that others had not spotted, that was actually addressed based on that scan alone.
We had one of the patients with prostate cancer that we sent over to Dr. Almeida, and as a result of his testing at Dr. Almeida's, he found out that he had another cancer that was much more aggressive. So he had to treat the other cancer first, and then they treated the prostate cancer, and the guy got better. That's the guy you're talking about.
Okay, we have time for some more questions after we hear from Gene. I just wanted you to know that picture here is me. Okay, And my prostate cancer is spread into my seminal vesicles. And the point of this exam is where else did it go? And the first thing is a typical CT scan or an MRI scan. The shades of gray. It requires a real craftsman to do that. It's not cancer specific. It will show inflammation, enlargements, and say that it may look like cancer, may not. Here we have, because of the injection you take and from the cyclotron, bingo, you see where it is right there. It's in the prostate and the adjoining seminal vesicles. It's nowhere else. And that's the critical benchmark. It hasn't spread yet, but it's been established. So I go back to see him. In between, I go get a sodium fluoride test, which is covered by Medicare, and he wants me to do that, and I've done that, and I show it's not growing. But my point of emphasis here, it relieved a tremendous amount of anxiety, because prior to that time, the attitude was, well, we don't find anything, but again, we can't see something like that. Well, here you can see it in the lymph nodes and in the seminal vesicles and so forth, which most others cannot.
Okay, further to that, when you say to yourself, okay, now what am I going to do? So what's happened is we send people over to Alameda, and the thing is that it has to be of a size that they can see it. And that's a real problem, because if your PSA starts going up and your tumor, the activity is still small enough, you can't see it. I mean, obviously in this image, it lights up right there, just like a crab shack, eat at Joe's, you know? It's very obvious. So then, how do you treat this? Well, this can be treated either by, depending on the size of it and where it's located, by IMRT radiation. It could be treated by CyberKnife, which is a more precise beam. It could be treated by cryoablation, which is freezing, or now we know about laser ablation. So those are all things so that you treat only the target, so that you can get in there and just get that. So once you get that information, you take it to a smart doctor, and you decide what you're going to do about it. And we've had, I don't know how many now, lots. We've had lots of guys that have reoccurring prostate cancer following surgery especially, that we've been successful in treating them. So, I think I'm through.
Lyle, who is the doctor you said that is doing the Gleason scores by MRI, via MRI?
They're John Kurhanowitz at University of San Francisco, California, San Francisco. Now, he made a presentation at the PCRI conference where he presented this evidence. So I just gave that information to someone else earlier. But if you want that, you go John Kurhanowitz, UCSF.
Thank you.
He's the guy that originally did I participated in the original clinical trials using spectroscopy imaging with MRI.
Okay.
Thank you.
I'm hung up.
Don't forget to get your testosterone checked.
Okay, hopefully you can hear me okay, right? So I'll use that. You roll down to it. Okay, let's talk about taking care of yourself while you're going through this. It's been said several times so far to don't take quick steps. And whatever the steps you're considering, find about your doctor's experience. If you're out there in an advanced case of prostate cancer, you may be well beyond his expertise already. Ask him about what the side effects can be in what you're doing. And if he doesn't know, as John suggested, you better find somebody else. And I'm going to speak to that very specifically. And someone was somewhat critical about what we often say in this group. There's a group of doctors up in Marina del Rey who are prostate oncology specialists. And all I want you to do is think about this. If you have prostate cancer, oncologists treat cancer, why wouldn't you see doctors that only deal in prostate cancer? That's why I'm there. I got led there by this guy after I had done surgery, failed, did salvation radiation, failed. Fortunately, this person said, I know this guy named Lyle LaRosh has a support group. Why don't you check it out? I did. After one meeting, I told Lyle, I said, I've got to be involved with this stuff. And you've heard me say many times, he convinced me I wasn't going to die, because I was sure after 2 failures, I'd had surgery, I'd had radiation, I must be faced with death. And I'm not. Now, I've gone through many, many things since then. I've got involved with the doctors in Marina Del Rey, and they recommended a couple of alternatives, all of them relating to hormone therapy, the common word, or ADT, androgen deprivation therapy. And I chose Casodex as my first treatment. That worked very well for me for 4 years. I became resistant to that, and that's typical. And I had to choose Lupron, which I didn't want to do in the first place because of all of the horror stories you hear about the cold sweats and so forth. And there's answers to that, which I'll cover a little bit. And I'll be darned, last appointment in December, it showed signs I'm starting to resist the effects of Lupron. So now I have gone to another treatment, and I have discovered through imaging, the F-18 imaging, that I have started to have bone metastasis to get into the area that you're concerned about. And there's another newer treatment called Xofigo that goes to the area of the cancer in the bone and minimizes that cancer. It actually kills that cancer without affecting any surrounding tissues. And I started that in January. I go in next week for my 3rd treatment. That's a treatment of a shot every month for 6 months. And in conjunction with that, I started the newer drug called Xtandi, which is another hormone therapy treatment. Now, I'm not having side effects from those seriously. And that takes us into the quality of life factors, because whatever treatment you do choose, you're going to be affected somehow, except the lucky guy up here that is qualified to do active surveillance. So learn all you can about what the side effects possibilities are going to be for whatever treatment you select. I'm going to have a slide here in a minute that really jumps out as to what you can do about it. But the thing that I'm going to just hammer to death, and the guys get tired of me saying this, is the thing that has minimized these side effects in my case, and I think it would for almost anyone that has decent health otherwise, is diet and exercise. I was highly concerned about cold sweats. I watched my wife horribly go through the menopause, and I thought, man, I'm going to be there. And I said, boy, I don't know if I can handle that. And I do go to the doctors up there, Dr. Lamb, and I says, how can I best avoid these problems? I was really worried about bone loss, muscle loss, fatigue, all of those nasty words you hear, and they will happen if you do not do something about it. There's treatments available for it, but Dr. Lamb said, get to the gym and exercise. I rolled my eyes. I hate the gym atmosphere. I said, I just don't want to do that. Fortunately, I have a Y within 3 miles of my house. I got involved, and I'm kind of an addictive by nature, I got addicted to the gym. And I go there 6 days a week. I'm there an hour and 15 minutes every day. And I want to tell you, I don't have side effects. Yeah, I have blushing, or I call it a flush, from Lupron. Yeah, I get a little tired, but I refuse to allow it to happen to me because I have now built my body back to the condition that I can overcome it. So just keep that in mind. Whatever you do, exercise, exercise. Doesn't matter what kind you do, ride a bicycle, do what you can, what you're capable of doing, and establish a habit. I get up in the morning, first thing I'm going to do is go to the gym. So I beat it to death, but I'll continue to beat it to death because it works. Okay, so another area that we want to talk about very seriously, I don't know what happened to our picture here. There we go. The quality of life factors, and I'm going to move on down to that slide now and talk about it a little bit. This I've kind of alluded to here, but let's talk about it just a second. These are all things that you have to think about, whatever treatment you choose, and that's what you got to ask your doctor. If he leads you towards any kind of a treatment, ask him which one of those things is going to be happening to you. And if it does, what he can do to help you overcome it. Because in almost all cases, except a couple in there, the penile shortening, I don't think he can help you with that. That's related to surgery and so forth. The other slide's going to show you that. But the bone loss, the loss of libido, if you're on active ADT as I am, it'll happen. You will lose libido, but ladies still look good to me. Even I've been on it for years. Do anything about it, that's a different story. Muscle loss, yes. Depression, be careful of that one, because it'll grab you before you realize it. You don't know you're slipping into it, and that's the importance of having your spouse working with you, because the spouse will pick it up far sooner than you realize it's happening. And it has happened to me. And I tried some medications to help overcome it, and I found out that the best medication was being aware. And I stopped taking any medications to take care of it. So just be aware. Those things are going to happen. Pick and choose them, because you are the ones that has to determine what lifestyle you want. So find out whatever treatments you're heading towards, which one of those things is going to pop up or is likely to pop up. And you have to do a lot of research on that, because when you talk to your doctor about it, he's going to downplay that. He's not going to open up with you about it, especially in whatever he's trying to get you to treat, whatever treatment he's trying to get you to take. So let's go on down here to this. This is just a wonderful slide that PCRI put out, and George embellished it a little here because it's really important to look at. Just go down the list and look at it on the possibilities of the impact of which treatment you choose. Surgery, okay, you can see what they are. And of course the number of stars or whatever they are is how likely it's going to be. Radiation, not quite so bad in most cases. Androgen deprivation therapy, hormone therapy, which I've now been on for 8 years. Yep, every one of those suckers. However, I have overcome every one of those suckers except the ED and libido loss. Like I said, the ladies still are attractive to me, but okay. So look at that very seriously, and that leads me to the last area of discussion, and that is active surveillance. and you've heard it mentioned through here. Before I slip in there, I want to back up and talk about one thing more, and you've heard it mentioned, but I don't think we've hit it enough, and that's the importance of imaging. Imaging, imaging, imaging. The minute you get to your doctor, he's going to want you to do something. We say, get it imaged first. The doctor's going to try to take you, if he sees that there's an issue with you, he's going to try to get you to do a treatment. Get imaging first. If you're lucky enough to not have had a biopsy yet, get the imaging before you do the biopsy. Because Lyle discussed it very thoroughly. You can get a picture of where the problem is, and you get the biopsy truly of where that problem is. And there are sources for it. He's mentioned Duke Bond up in Marina Del Rey. The doctors Lamb and Schultz also do the color Doppler ultrasound. That's what Duke Bond does. They now also do biopsies. Shortcomings can be insurance. Duke Bond doesn't take insurance. The guys up in Marina Del Rey do. So the problems start to become, you know what you want to do, can you get it done with your doctors? And that's where this group comes in, because if you decide you want to do something, get on the horn and find out from us, and we're going to find some guys that have been through it or are going to doctors that can help them do what they want to do. The hardest part, and then whether or not you can deal with it from your insurance standpoint, that's a real bugaboo. Finding out, if you know what kind of treatment you want, the second part of that equation is, where can I go to get it done, and will my insurance cover it? And that's a real problem. If you're on Medicare, it's not a big problem. But those that haven't reached Medicare yet, it can be a big problem. So, one more slide. Oh, that's my favorite. What can you do about it? And that's to join a support group. We've all been through it. We all have different experiences. Your case is never going to be the same as someone else's exactly, but there's going to be a lot like it. One of the most important things is to remain positive. And I know that because when I saw this guy, I couldn't have been any further down because I'd failed twice, and it took a long time to bring my mentality up to where I was really thought I would do something, could do something about it, because I was sure I was facing death. And remember that's a really good percentage when you look at it, isn't it? 95%? That's really good. I've survived 13 years. That's pretty doggone good. You've seen the other guys. So, another really, really important thing is to keep your family involved in what you're going through. Because if you try to keep it from them, that puts the pressure on you to, you know the story about telling a lie? You don't tell a lie because you have to remember what you said. And you're going to get yourself in trouble. So keep your family involved with you to help you along. I found out something really interesting with my wife as I took her up to see Dr. Lamb at one of my appointments not long ago. And I talked a lot of things with him, as I usually do, and I come away from the appointment, we're driving home, and we talked about a certain subject, and I said, well, he said I should do this. And she said, that's not what he said. Weren't you listening? They hear what you're supposed to hear. We often hear what we want to hear. Remember that. So, and again, the most important tool you can have, and you've started doing it here today, those of you that are newly diagnosed and here for the first time, is knowledge. And if you learn about your condition, it can give you the comfort to put you in control. Our buzzword is become your own case manager. That's enough for today, I think.
One more thing.
Okay.
I'd like to acknowledge something. This complete PowerPoint presentation was presented and made up by George Johnson. And we followed his script, and that's fabulous. This is going to be made into a DVD, which we hope to circulate all over the United States. Thanks for coming.
Thank you.